Good morning or good afternoon. The webinar will begin momentarily.
Dr. Fidelik, 1, 2, 3.
Yeah,
I have 6 questions. Am I missing anything? I copied that from the email thread.
I think that's okay.
Okay. It was two days ago.
Great. Okay. Thank you all for joining today's webinar, Intersectional Differences, Exploring Healthcare Barriers and Access Using the All of Us Researcher Workbench. I'm Angela Balfour Franklin, Engagement Lead for the All of Us program at Community Campus Partnerships for Health. Together with RTI International, we welcome you to today's webinar. Please feel free to use the chat to share your questions, comments, and reflections during the seminar, this session. You'll also be asked to fill out an evaluation survey at the end of the webinar. Your insights will be used to help make programming decisions. So I'm asking you to please take a few moments and fill out the survey. We really do want to hear from you. Thank you. Next slide, please. Our agenda today has already begun with the welcome and logistics. I'm going to take a few moments and tell you a little bit about Community Campus Partnerships for Health, and then we'll have our first presentation by Dr. Sula Hood, and we will then have our second presentation by Dr. Miguel Antonio Fudalik, as well as a fireside chat, which will include Drs. Batra and Johansson, after which there'll be a few announcements and updates, the evaluation survey, and then closing remarks. Next slide, please. Who we are. Community Campus Partnerships for Health promotes health equity and social justice through partnerships between communities and academic institutions. We view health broadly as physical, mental, emotional, social, and spiritual well-being, and we emphasize partnership approaches to health that focus on changing the conditions and environments in which people live, work, study, pray, and play. Next slide. What we do. At Community Campus Partnerships for Health, we help solve challenges like a lack of trust between communities and institutions, unequal power dynamics and research partnerships, limited capacity for sustained community-engaged collaboration, and we help solve challenges like disconnects between public health research and real-world impact. Our focus areas are building and restoring equitable, trust-based partnerships, leading capacity building efforts that strengthen community and academic collaboration, and supporting community-driven research, policy, and practice that lead to sustainable change. Next slide. And here is the team that does all of that at CCPH. We are led by our executive director, Al Richmond, who some of you may know, as well as Keisha Vines, our strategist, as well as part of our production team, and myself. Next slide. For the researcher academic overview, I am pleased to introduce Dr. Sula Hood. Dr. Hood is a senior research scientist at RTI, a nonprofit research institute. She has over 17 years of experience with a focus on health communication and community engagement in genomics. Dr. Hood is a co-investigator on RTI's All of Us Engagement and Retention Innovator Award, and she serves as co-lead for the All of Us Researcher Academy. Welcome, Dr. Hood.
Thank you so much, Angela. You could advance to the next slide, please. And thank you all, everyone who is online today, for joining. Before I talk a little bit about the Researcher Academy, I just want to acknowledge our team. As you can see, we have a large team of individuals that make the Researcher Academy happen. So I'm going to share a little bit about some of what we do for the Researcher Academy. Next slide, please. All right. So before I let you know specifically what the Researcher Academy is and what we do, I just want to provide a little bit of foundation about how we fit with the All of Us Research program. So the NIH All of Us Research program is a historic effort to collect data from 1 million or more individuals across the United States to learn about all different types of health indicators and variables and health outcomes to help inform precision medicine and advance individualized care. The All of Us Researcher Academy that I co-lead provides training and technical assistance for individuals who are interested in analyzing the data that is gathered through the All of Us research program. They utilize the All of Us Researcher Workbench, which is a cloud-based platform where the data can be analyzed from the various participants that have been recruited for All of Us. Our All of Us Researcher Academy supports peer-to-peer learning. So we're largely focused on networks and making connections amongst researchers as well as students. Next slide, please. All right. So as I mentioned, networking is really pivotal when it comes to our Researcher Academy. And so our goal is really to establish a large and sustainable learning network of researchers who utilize the All of Us data. And so we promote access to and utilization of the All of Us Researcher Workbench by researchers across the U.S. We have a range of objectives that we strive to meet to connect researchers to the data and to support their ability to effectively analyze the data. We do things like engage with researchers and institutions to raise awareness about the fact that all of us exist, as well as to assess researchers' needs so that we can appropriately support them in analyzing the data. We also have various different programs where we support researchers and help to connect them to the data, such as internships and fellowships. We offer a wide range of courses to assist individuals with developing the skills to analyze all of us data, as well as develop other types of skills related to dissemination and things of that nature. And I'll talk about that a little bit more here in a few minutes. We also provide technical assistance. And so we have a group of researcher workbench coaches that work very closely with individuals to ensure that they can effectively do their projects utilizing the All of Us data. We build partnerships, and we continuously do ongoing evaluation of academy activities to ensure our program success. So along those lines with evaluation, once again, we would greatly appreciate if you would complete the evaluation at the end of this presentation segment, or today's webinar rather, so that we can have your feedback to use for future offerings. Next slide, please. All right. So one of our program components that I just would like to share a little bit about is our Institutional Champion Awards. And these are small funding awards that support teams in conducting research using the All of Us data. And so these are interdisciplinary teams of individuals at academic institutions from various different disciplines. And the funding is used to support and cover the expenses for faculty members or postdocs or students. Each Institutional Champion awardee receives up to $75,000 to support their team's All of Us research for 1 year. To date, we have funded 21 institutions across the country, across 4 groups, and so we're really proud of that. Next slide, please. All right. So as I mentioned, we have a wide range of courses that we have developed over the past several years to provide information about how to navigate the All of Us Researcher Workbench, to providing background information about statistical analyses so that people are more proficient in how to analyze All of Us data, writing up manuscripts, applying for grants. So we have a wide variety of resources for a range of learners. They are freely available online through our Amaze platform. And we have developed a course catalog so that individuals can learn a little bit more about the courses, and each course description also has a link to access the course. And so when we send out the slides, you can either click on this link, or currently, if you have your phones available, you can click on that QR code and scan it to access our course catalog. But once again, our courses are freely available. There's no cost associated with them. Next slide. All right. So another resource that I'd like to share with everyone is our Researcher Academy newsletter. It's called Connections. It comes out on a quarterly basis, and we have almost 800 subscribers. For individuals who are on the call today, if you are not currently subscribed, I certainly encourage you to subscribe, and you can do so utilizing the QR code below, or it will be linked in the slides that are sent out. But this is a great resource to get information about all of the happenings of the Researcher Academy. We feature researcher spotlights for research investigators that are affiliated with the Researcher Academy, so that we can showcase their research. We provide announcements about opportunities and programs that are offered through the Researcher Academy. And we also share about upcoming events as well. And so once again, you can access our newsletter utilizing the information below. And you can also go and read previous versions. It is a digital newsletter, so you can go and read previous versions of it as well. Next slide, please. All right. So now I want to talk a little bit about the All of Us Researcher Workbench. Next slide. Okay, so as I mentioned, the All of Us Researcher Workbench is the place where data analysis happens with the All of Us data. It is a cloud-based platform that houses All of Us participant data. There are multiple tiers where you can access the data. The first tier is the registered tier, and it contains individual level data only approved to researchers on the researcher who register to utilize the Researcher Workbench. But it includes data such as electronic health records or survey data and things of that nature. But then our control tier is the tier that contains more sensitive data. And so you would have access to suppressed demographic fields from the electronic health records that you wouldn't necessarily get if you registered for the registered tier. And I will say, and I'll talk here in a moment, in order to be able to utilize the Researcher Workbench, you have to actually register and sign up and go through a online process for doing that to access the data via either one of these tiers. If you see over here to the right, the All of Us data set is just so great because there's so many different sources of data. As you can see here, there's survey data and genetic data and wearables data as well, and physical activity, all different types of data on a variety of different health behaviors and health determinants as well. So I certainly encourage you to visit the All of Us site and learn more about the Researcher Workbench and the data that is available that might align with your area of interest that you might be able to study. Next slide, please. All right. So in order to be able to access and sign up to register to use the All of Us data, the first step is to make sure that the institution you're affiliated with has a data use and registration agreement, or a DURA. This is a umbrella agreement that links different users to be able to access the data. So for example, I'm at RTI International, and we have a DURA in place. And so my email address that is affiliated with RTI International will allow the All of Us admins to connect my affiliation with an institution that has an approved DURA. So DURAs enable researchers to access the registered tier and the control tier data. And it's managed by our colleagues at Vanderbilt University Medical Center. So if you aren't registered, the first step is to, you can scan the QR code and go and check to see if your institution has a DURA. When you go to that site, there'll be a drop-down list, and you can put in your institution and see if your institution has a DURA. If your institution does not have a DURA, you can go through the process of requesting for your institution to get a DURA, so that individual investigators at that institution will be able to access the data. Okay, next slide, please. All right. So once an institution, it's been determined that the institution has an approved DURA in place, it's a pretty seamless process for individual researchers to register. First, you confirm your institution's agreement that they have a DURA in place. You create an account with the Researcher Workbench, and then you can complete the mandatory training. And this training focuses on research ethics, something similar to what you would do if you, for example, go through city training. And then finally, the fourth step, all investigators utilizing the Researcher Workbench are required to sign a data user code of conduct. And this is something that is renewed and signed on an annual basis in order to be able to stay active. We have the QR code over to the right, as well as a live link for signing up for the Researcher Workbench if you're interested. Next slide. All right. And then finally, during the Researcher Workbench sign-up process, you'll be asked a few questions about how you learned about the Researcher Workbench. We would greatly appreciate it if you do proceed with that process, to acknowledge that you learned about it through the Researcher Academy. And so we have some screenshots here where you can select that you've learned about it through a presentation, and more specifically, the All of Us Researcher Academy, or RTI International. All right. Those are the steps for how you sign up for the Researcher Workbench. Once again, I encourage you to go to the All of Us site and learn about all of the different data sources and various different variables that the data set has to offer, as well as sign up to utilize the resource. Okay, next slide. All right. So now I would like to take a little bit of time to introduce our featured presenter for today. Dr. McGill Fadalik is currently an assistant professor in epidemiology and biostatistics at the University of Nevada, Las Vegas School of Public Health. He received his PhD in statistics from the University of Nebraska-Lincoln in 2022. His research interests are threefold: health disparities research, applied statistics methodology, and epidemic modeling. He is currently the Southern Vice President of the Nevada chapter of the American Statistical Association and the faculty advisor of 2 student groups. He also mentored 3 students for the All of Us Researcher Academy at UNLV. So I'd like to just welcome you and thank you so much for taking out time to present today, Dr. Fadalik.
Thank you. Let's see if I can make this full screen. There we go. So thank you, Angela, for the uh, thank you for the introduction. So I am Dr. Miguel Fadolic. I am from the All of Us Researcher Academy team at UNLV. I am an assistant professor in the School of Public Health, and I'm here to present our study about intersectional differences, exploring healthcare barriers and access using the All of Us Researcher Workbench. So you see our team here, and we have our PI, Dr. Christopher Johansson, who will be present for our fireside chat after the presentation. So first, we'll acknowledge people who have helped this study to be successful, and then I'm going to show a little bit of background of why we did this study and discuss a little bit more about the All of Us data set. I know that Dr. Sula Hood talked about it earlier. And then we're going to get into the meat of our study, which is the objectives, methods, results, and what are the implications of our results. So I'd like to acknowledge the following. So we'd like to acknowledge the funding as an All of Us Researcher Academy institutional champion, sponsored by RTI. And I would also like to thank Drs. Stephanie Tillman, Hunter McGuire, and Barrett Montgomery for their assistance that they gave us to complete this project. They're all part of the All of Us Researcher Academy. So why are we here, right? As professionals in the School of Public Health, we want to improve the quality of care received by the community. But to improve the care that they receive, we must get them there first. So we want to address the barriers that they face when coming in to your clinics or your community health centers, right? You can't just tell them to show up. You have to ask them, why aren't you showing up? And usually underserved and disadvantaged communities experience these barriers, right? So when these barriers are in play, what happens is you get delay of care, and that could lead to poorer health outcomes in the future. So this avoidance of healthcare specifically, we can look into like why some groups avoid getting healthcare. So one is sexual and gender minority groups. So some previous studies have attributed it to identity discordance between patient and provider and previous experiences of discrimination. And in racial and ethnic groups, there is an additional layer to it where it's attributed to historical events, like for example in the Black community you have the Tuskegee trials, and also potential of cultural misunderstanding between patient and provider. This is very common when there's no understanding across different race and ethnic cultures, and then also experiences of discrimination. So all of these could lead to some person saying, I don't want to go to the doctor. I don't want to go to my provider because I feel this. Now, some in the previous literature, you see like looking into sexual and gender minorities separately from racial and ethnic minorities, but sometimes we have groups that have both, like are part of both minority groups. And one way to look at a person holistically is through intersectionality. So intersectionality is the overlap of multiple social identities, and how they shape with oppression and discrimination. And this is the visual representation of intersectionality. So you can look at the cultural dimensions, but it's not just that. You have the personal contextual factors, relationality. Are they are they parents, for example? You have the systemic factors. Has there been anything that has gone wrong for this group in the past? And then you have the isms, which is perceived experience conflict. So all of these define how we perceive things, and um, that's why it's important to not just attack from one axis, but as many axes as possible to have a better view of what is actually happening in our population. So different forms of social inequalities. It's not just racism, it's not just sexism, it's not just classism, it's not just ableism. They all work together and influence health. So, like I said, it could affect delay of care, right? And other health outcomes. So instead of looking at factors like race, gender, sexual identity in isolation, we want to look into how these identities interact using the intersectional approach. So, what are the barriers to healthcare? So, there are two previously found categories of barriers. So there's cost and non-cost. So there are economic reasons to delay care, such as copays, deductibles, and out-of-pocket costs. You can also say that if you can't take time off from work, that's also a cost barrier. And then there's the social cultural barriers that are not related to cost, such as identity discordance, availability of childcare, for older adults, rurality of residents, lack of transportation, anxiety, or nervousness. So to address this, we need to have data, right? And that's what the All of Us research program gave us. So it is an initiative, like Dr. Hood said, that they wanted to recruit and follow 1 million participants from underrepresented communities so they might accelerate advances in biomedical research and precision medicine for everyone. So we want representation from those historically underrepresented communities, and that's what we got. And as Dr. Hood discussed earlier, there are a lot of data that are available. So you have the EHR, participant surveys, genomics data, physical measurements, and wearable tech. We focus on participant surveys in this case. And across the different tiers, we use the control tier to look into what demographic variables are there available and what could we work with. So with this data set, we want to identify barriers to healthcare access faced by intersectional identities, and we want to compare the likelihood of reporting barriers for different intersectional identities. So we're going to see how this differs between like other literature and this study later on. So what we did was we used the cross-sectional design using the All of Us Researcher Workbench, where you can do the statistical analysis, like Dr. Hood mentioned earlier. It is a cloud-based platform. So it provided different interfaces for Python, R, and SAS if you are interested in using the Researcher Workbench. And what we used is R in the uh, Jupyter Notebook interface because it's cheaper. And so one of the things that you can use the All of Us Researcher Workbench for is the cohort builder. So you don't need to use the very big data set available in the All of Us Researcher Workbench. You can make a cohort and it will filter it out for you. So here are our inclusion criteria. So we looked at ethnicity reported as Hispanic, non-Hispanic, or none of these. Race reported as the following: white, black, Asian, more than one population, which is multiracial, Middle Eastern, North African, and Native Hawaiian or Pacific Islander. It also gave us gender identity with woman, man, transgender, non-binary, additional options, and unknown, and female, male, unknown, none, and intersex. Now, there were exclusion criteria that we used. So there are people that reported more than one sexual orientation. So we don't know if it's faulty reporting or if they do identify as more than one sexual orientation. To avoid that problem, we took these out and answered none of these and prefer not to answer. So we couldn't really determine what their racial and ethnic identities are. And the total sample size was 405,307 participants. So if there were missing responses, we used list-wise deletion. And part of the Dura is that you have to have at least like 20 for each group that you're analyzing, at least 20 samples. And because of data sparsity, when we're trying to include more groups, more intersectional groups, we try to aggregate them instead of excluding them. So Asian Americans and Native Hawaiian and Pacific Islanders are grouped into A and HPI, and then you have the other group for the multiracial Middle Eastern North African. We're not going to talk about the results for that group because I don't really believe in like aggregating these together. But we also wanted to account for the variability that they have. And then transgender men and transgender women were aggregated into transgender to improve statistical power. And then these are the reported reasons for delay of care. And these reasons include transportation, lack of transportation, rurality, nervousness, time off from work, childcare unavailability, caregiver for older adults, and then you have the cost issues, co-pays, deductibles, and out-of-pocket costs, and then provider identity discordance, specifically race and religion. We use two-way interactions to account for the intersectionality. So we have race and sexual orientation and race and gender identity as interactions. That means groups are defined by a combination of these two variables. So why not three? Well, because of data sparsity. Like as much as all of us data set, try to be diverse, there's not a lot of representation for some of these groups, and so we decided to just use two-way interactions. And the effect sizes were measured using adjusted odds ratios, and confidence intervals were adjusted using the Tukey-Kramer adjustment. But since there are intersectional groups that have lower sample size compared to others, we can't really conclude a lot based on some contrasts, although we can give effect sizes as mentioned as in the form of adjusted odds ratios. So for our results, we have the following demographic variables for our cohort. We have median age is 25 with an interquartile range of 29. As you can see, most of our cohort is still non-Hispanic white, but there are sizable representations for the NA and HPI, non-Hispanic Black, and Hispanic population. For sexual orientation, we have a lot that identify as heterosexual, but we have a pretty respectable representation of bisexuals, gays, lesbians, and queer folk. So if they answered none as part of the sexual orientation, we assume that this was going to be like the listed options weren't there, so they didn't identify with the listed options. Sorry. Therefore, we it still included them as none. And we have 2.08% of them. And then gender identity, we have predominantly women, then we have men here. And we also have a sizable representation of non-binary transgender population. Most of them have a college undergraduate degree and also advanced degrees in college graduates. There's also very sizable representation for GED or grade 12. And for insurance status, 90.07% of participants reported to have health insurance. So we can take that out of our analysis because, well, they all reported to have insurance, almost all of them. And then most of our participants earned between 10,000 to 100,000. And then there are sizable representations from less than 10K and 100 to 200,000 annual income. So among these cohorts who answered the survey, the three most reported barriers were out-of-pocket costs, which is 18.18% of who answered the survey, nervousness, and patient-provider identity discordance due to race and religion. And then for other barriers, we still have a sizable reporting rate of inability to take time off from work, deductible, and copay. So this is very notable because the cost barriers are pretty high up in terms of how many people reported it. But we can see that in the top three, we have nervousness and patient-provider identity discordance, which are not cost-related. So you could see in this graph, so we're going to discuss the top three barriers that were reported. So this is out-of-pocket costs. I know it could be pretty hard to see, but the presence of the wide error bars here indicate, of course, like data sparsity, and there's a lot of variability in this group still. But what you could see is that there are some differences across sexual orientations and how they reported out-of-pocket costs. So we have these. So it's in the bisexual community, we have a pretty close close differences between the four racial groups that we have. And then if you compare that to the gay community, there's a lot more variability in that. And then for gender, we can also see like in the non-binary and transgender community, there's a big variability again due to data sparsity, but the point estimates also show something different. Like for those who identify as men, they're pretty much lower in terms of probability of reporting compared to gender minority groups. So like women, transgender and non-binary participants. So numbers wise, individuals who identify as bisexuals were 70% more likely to report delaying of care compared to heterosexual individuals after averaging over all race groups. And if we want to be specific in terms of effect differences, gay non-Hispanic white participants were 89% more likely to report out-of-pocket costs compared to gay non-Hispanic Black participants. And we could see that in the estimates that we showed. As for race and gender, for non-Hispanic white participants, non-binary and transgender and women were all more likely to report delaying of care due to out-of-pocket costs. But for non-Hispanic Black participants, men were less likely to report this compared to women. For nervousness, we could see another big differences across the different sexual orientation groups. The queer folk or the nun group, right, also has a lot of variability when it comes to the reporting probabilities for each race. But pretty notable is that how bisexual individuals report a really high uh, percentage of feeling nervous and delaying care because of that. Compare that to heterosexual individuals, where it's much lower compared to the sexual minority groups, right? So these are things that we typically don't see, because if we look at just race and sexual orientation separately, then we don't get these differences across groups, right? And same thing with race and gender. We could see that for men, those who identify as men, we have a lower reporting probability um, compared to women, and both these genders are lower compared to transgender and non-binary folks. And this is it's not shocking, but it's also a very compelling result, right? Because we could see like they're delaying of care because they're nervous to go to the doctor. And we don't really know why, but it's something that we need to address if their reporting probabilities are that high, around 40%. So for queer individuals in the non-Hispanic white population, they have the highest reported rate of nervousness at 40.5%, followed by bisexual individuals. And compared to heterosexual individuals, queer and bisexual participants were 3 times more likely to report nervousness as a barrier, respectively. And for and one thing that we also looked into was among the bisexual and queer participants, there were no statistically significant racial and ethnic disparities in reported rate of delay of care due to nervousness. So we could see like there are some differences across different racial groups for the heterosexual population, but not in bisexual and queer participants. It could be a statistical power issue, but if you look at how the point estimates are really close to each other, it could also show that there is some effect or like some amalgamation of being in like knowing or relating to the struggles of one another. And for gender groups, non-binary and transgender, like I said, reported higher rates of delay of care. Specifically for non-Hispanic, Black, and Hispanic populations, women were less likely to report delay of care compared to non-Hispanic white women. So that's also something that we saw in our data. Yeah, and then identity discordance. We also have this, and we could see that there is a lower reported probability for the non-Hispanic white group compared to the racial minorities across different sexual orientations. We also see that here in the gender identity plot. And as we expected, non-binary and transgender groups also show higher probability of delaying care due to identity discordance. And these are some of the results that we have. Like I said, non-Hispanic white participants reported the lowest rate of care, even for heterosexual participants. In Black and Hispanic participant groups, bisexual and queer participants had the highest reported rate of delay of care. For Asian American and Native Hawaiian and Pacific Islanders, queer and lesbian participants reported the highest rate of delay of care. This could be a cultural thing, but again, we aggregated them, so can't really say for certain. And then for cisgender participants, men were less likely to delay care compared to women due to identity discordance. Similar trends were observed in non-Hispanic white and Hispanic participants. And across all racial groups, non-binary and transgender groups were reported the highest rates of delay of care. So we found disparities in the reporting rates of the different barriers, and the 3 most reported barriers were out-of-pocket costs. identity discordance, and nervousness. And it's a mix of both cost-related and non-cost-related barriers. So we can't really just say we have to address the cost of health. It's more than that. So it could imply that there is stigma experienced by intersectional minority groups from healthcare providers, and that could have been a factor in like nervousness and identity discordance. There could be cultural differences that could have caused hesitation in availing healthcare, and of course, the cost-related barriers could be related to economical factors, and this happened across axes of intersectional identities, regardless of whether they're a minority group or not. So limitations, we have associations, they're not causations, limited representation for some intersectional identities, and there is some groups with sparse data, so we couldn't really add more covariates to it, and there could be lack of power as well. An example of that would be the ANHPI, which had low representation for some SGM groups. So we recommend that moving forward, we account for intersectional identities in addressing barriers to healthcare access and also public health issues. And one of the things that we are working with is to identify clusters of reported barriers to healthcare access and experience discrimination. So thank you. That ends my presentation, and I think we're going to go into the fireside chat with Dr. Johansson and Dr. Batra from our team. Angela, do I introduce them, or will you introduce them?
If you don't mind, Dr. Fadolic, I think it would be great if you could introduce them and then go right into that fireside chat / Q&A for the attendees as well to participate. Thank you.
Okay. So I will be introducing our team members, Dr. Christopher Johansson and Dr. Kavita Batra.
Hello, everyone.
Yeah, and this is Dr. Johansson is the PI for the All of Us Research Academy Institutional Champion Grant through RTI, and his research interests are in social and behavioral health. Sorry, I don't have the email of the introduction. Yeah. And then Dr. Kavita Batra is part of the UNLV School of Medicine. I think it would be better for you to just introduce yourselves like more specifically. But yeah, I'll give the floor to the two of you, and we can start with some of the questions that are left in the Q&A, and maybe some of the questions that we also formulated towards the group. So
Absolutely. I'd just like to interject for one moment. Keisha, if you can make sure that you're not sharing your screen anymore. And then it looks like she is not, so we can continue by having Doctors Johansson and Batra introduce themselves. Thank you so much.
Where do I? Yeah, my name is Chris Johansson, assistant professor at the UNLV School of Public Health. Yeah, just for the sake of time, we'll just get there because we have like 10 minutes left, so I want to get to that conversation. So.
Thank you, Dr. Johansson. Hello, everyone. This is Dr. Kavita Batra. I'm Executive Director of Medical Research and Scholarly Activities with the School of Medicine at UNLV. But I'm not sure, Angela, if my question is visible in the chat or not. Just wanted to check.
Actually, it is. And even before your question, an attendee had a question for all three of you. And that question was income per capita or household?
I think I would have to check again, but I think it is per household, right?
Yes, I think that as well.
Yeah. If you're interested in the specifics of how it was asked, you can look into the All of Us data browser, and I think Dr. Hood, you can link the All of Us data browser to check what exactly were the demographic variables and the survey questions that were asked in the survey.
Thank you both. And Dr. Batra, we do see your question, and that is, are you preparing any follow-up studies using the All of Us data, Dr. Fudale?
Yes. So we made this cohort because we wanted a multifaceted research study. So this is just one facet of it. The other is looking into overall physical health, and then the other another study that could come out hopefully this year is to look at the profiles of stigma that are felt or experienced by SGMs and racial and ethnic minorities using an intersectional approach. So, Dr. Batra, you would like to add?
Yes, we also have one study which actually for which we applied for funding, but unfortunately we didn't receive that funding. But the idea was to look at the non-adherence medication behaviors among intersectional identities. Once we are done with this project, which are ongoing, we will be starting that new project, which was unfunded, but I think we would like to explore it further.
Yeah. I think there's also a question. So can community members access the data without being attached to a university? So Dr. Hood, would you like to answer that?
So in terms of the registered data, as I mentioned, a DURA or the data use agreement is required. However, there is a more of a public data browser where data that is very de-identified is accessible. And so people like students and people more in the community settings can access those for individuals who aren't registered.
Thank you, Dr. Hood. I appreciate you responding, and thank you, Dr. Fudalik, for pointing that question to Dr. Hood. I do have a question for all three of you, please. And it is, what are the implications of these findings for intersectional groups?
I guess I'll start. So the implications of these findings is there are some not arguments, but there are some issues that have been brought up about like this is my oppressed identity or this is my oppressed identity. I should be like I should be heard, right? And sometimes we don't really connect the two. Like, oh yeah, we're both suffering, but it becomes like how much suffering are you going through compared to what I'm going through? But in the intersectional, if you look at intersectionality, it's looking at it as a whole, and you're not excusing like one or putting one over the other. It's more like let's look at you from different perspectives and see like how we can help you and your group. Yeah, that's for me.
And I will add, I think Dr. Federic already mentioned about some kind of limitations with when we try to explore intersectionality in the data itself. And I will talk like statistically. Some of the groups really, when we did the analysis and when we apply more dimensions to come up with the intersectional group, like multi-dimensional intersectional group, the sample sizes were not enough for us to investigate the hypothesized effects. So one of the recommendation that our group would like to make is, better representation of those groups so that further or future studies can be planned.
Yeah, I'll just add to that. I guess maybe more of a question or a comment. Like, how can we how can we find those folks who are underrepresented in the intersectional groups? So I know the All of Us community engagement, and different folks have done a lot of outreach and made a large push to increase and have a very high sample size. But how can we reach those a little bit harder to reach folks in research in general?
Yeah, that's a great question. I also want to add policy implication here. So with this changed political climate these days, even like our group was like a little bit concerned about like when we are trying to publish our findings, which terms we are not going to use, or kind of like using some alternative terminology to maximize the chances of getting this product to the public or audience. So that was our other challenge with this existing political climate.
I agree. In fact, if you look at other conferences where we presented this, the titles were a bit different. So we've changed it in time. So yeah, we definitely have gone through that challenge.
Are there other challenges that you all faced?
Yeah, I guess like the researcher workbench, although like the research, all of us data set is all of us researcher workbench has a very good documentation. There's a lot of it that you can do, and you have to scour for it. So also looking into which variables can be put into there, how deep can we go through with our intersectional approach. Those are challenges that not only is on a personal or community level, it's also in the statistical analysis aspect of it. Yeah.
And I think one of the challenges that, not challenges, but I think when we start our analysis, the biggest thing that we have to take like a very thoughtful approach is when we apply our selection criteria and make our cohort, especially when we have like a lot of intersectional dimensions involved. That goes back again to my previous comment, like the as soon as we add more dimensions to it, our sample size decreases. And again, recommendation on how we can increase the representation of those groups. Kind of missing data analysis, the challenge handling missing data.
Doctors, Dr. Johansson, you'd like to add?
Go ahead.
Feel free.
No, yeah, I was just thinking. I was just gonna ask Dr. Fudalig. I guess what was the most surprising or interesting finding he thought, or like did this corroborate a lot of what kind of literature showed, or is there anything that kind of stuck out there? Like, oh, that let's look into that a little more. For me, I think it was like the bisexual kind of findings were kind of interesting and not really expected, at least for my limited knowledge. So I don't know. Did anything else stick out to you?
One more thing I want to add, especially with the heterogeneous categorization. So when we were looking at the current literature about how to classify STM individuals, so like there was a lot of heterogeneity how that classification was used. So kind of we were also like facing this challenge, like how to best come up with our cohort and the subgroups that we would like to analyze. So that was another challenge, especially in terms of heterogeneity of the population groups.
Yeah. And that,
Dr.
yeah, sorry.
Fodolic, before you continue, we have about 30 seconds.
Yeah.
And I'm going to leave us on a high note so that for those who are looking for that answer, that they can reach out to you by email. And when we send the recap email for this webinar, we will include that so that they will be able to hear your response to that question. I'd really like to thank each and every one of you for this lively presentation and discussion, honest, robust, particularly about talking about intersectionality in clusters. This has really been a very, very interesting and enlightening conversation. Right now, what I'd like to do is for every attendee to take a few moments to look and to use the either the QR code or to click the link for the evaluation survey. Will take a few seconds to give you time. It will stay on screen and for you to be able to just take a few moments. This survey is extremely important to us, and your comments and your suggestions, your responses are valuable to us. So thank you for taking just a few moments to look at the eval survey, and we'll continue. Thank you so much, Keisha. I'd just like to take a few moments to thank each and every one of you again. And Keisha, if you can go to the next slide, and to invite each of you to join us for our next All of Us webinar on July 23rd at 1 p.m. on the Association of Ethnicity, Race with Phenotypic Characteristics and Clinical Outcomes among Patients with Hypertrophic Cardiomyopathy in the All of Us Research Program. Thank you all very much for attending. Thank each and every one of our presenters for, again, this wonderful presentation, and I hope to see you on July 23rd. Thank you all very much.
Thank
you.
Thank you.
Thank you.